difficult. But I'm going to shift gears a little bit because this is something I really want to get your insight on, because you're in Michigan and you're a tertiary referral center. You have all those surrounding areas and people have no access, and you sort of build out this teledermatology program out there, and maybe you can give us some experiences in terms of you sort of did this way before COVID happening, right? And maybe you can tell us do patients take the pictures, send it to you, or the physician send the picture to you, and what that process is like, and also what are the pitfalls that people should be watching out for when they take those pictures? Because without the good pictures, and you cannot make the right diagnosis, right?
Right. So, I have the opportunity I'm lucky to have working in two places, one at the VA, the other one is at the university. So, and I have the privilege to working of different kinds of telemedicine opportunities, from what we call a store and forward or asynchronous teledermatology to synchronous, or what we call as video visits. So I'll talk about the video visits in the later half. First, let's get to the asynchronous visits, I think, which is most suited for all dermatologists. So we created this, what we call as e-visits, which are basically at the university, where patients are followed up based on what they have by images taken by the patients, and they are sent through a HIPAA-compliant portal. And it comes to the dermatologist or you to kind of review it and kind of prescribe or continue medications or change medications. So that's one way of looking at it. It's a direct-to-patient asynchronous telemedicine application. The second application is like at the VA, where we do a little more comprehensive, where we actually have patients coming to the primary care physicians. And the primary care physicians have what we call as a teleconsult technicians or nurses who are trained to take photographs. And these are nationally trained nurses who are good at taking photographs. These photographs are not just clinical; they also are dermoscopy-associated images, which kind of makes it from a kind of a real triage model to kind of management and recommendation model, right? Like you see, you know what it is, and you recommend what needs to be done. Whereas if you saw a pigmented lesion, Steve, that it would be hard for you to kind of say, okay, that looks like a pigmented lesion, but I don't know what it is, like whether it's a pigmented seborrheic keratosis or a basal cell or a melanoma. So, and it is a full spectrum from completely benign to a malignant status. So the way we did the other store and forward or the asynchronous technology is like after the veteran comes to the primary care, these images are captured, and these images are kind of sent through, again, a HIPAA-compliant portal to us. It all just queues up as in another interface for the dermatologist, and the dermatologist reviews each cases. And the beauty of it, as I said, clinical followed by dermoscopy. It's almost like that dermoscopy is 2D, whether you see in person or whether you see. So it's a 2D image, so it does not change. So as long as you get a good dermoscopy photo, you will be able to make that diagnosis. And then the beauty of this, again, is like once you diagnose, like let's say you saw a melanoma, we would bring that patient next day or within a week, and that's access, right? Means like that's so important. At the same point of time, if we are for sure know that it's a seborrheic keratosis, we tell them to stay back. So that's the huge difference, which we make that. That's the asynchronous part.
Before we get to the video part, I think you obviously highlighted the benefit, right? It's about access, it's about triage, it's about relieving patients' concern for benign lesion, and getting the right patient into your clinic faster and sooner, right? And so because you created the system.